Good evening, everybody. This is Mohammed Al-Umari. I'm a pediatric neurologist from King Fahd Hospital of the University, an assistant professor in pediatric department at Imam Abdurrahman bin Faisal University. I would like to welcome all of you into this webinar today. It's really a great pleasure to have Dr. Kawthar Hadiyah. She's a consultant neurologist and neurointensivist in King Fahd Hospital of University in Khobar, Saudi Arabia. She's an assistant professor of neurology, College of Medicine, Imam Abdurrahman bin Faisal University in Dammam, Saudi Arabia. Dr. Hadiyah got her neurology board in 2015, and then the Neurocritical Care Fellowship from Western University and McGill University on July 2017. She's an active member of a number of scientific societies and organizations. She had more than 15 published papers in well-recognized journals. She will be talking today about the brain death. Welcome, Dr. Hadiyah, and the mic is yours.
Thanks, Dr. Mohammed, for this introduction. And it's a pleasure to be with you today or this evening in our time zone to discuss an important medical ethical topic. We will go through a couple of things in that topic. First, to share my slide with you. So in this topic, we will discuss, or this evening we'll discuss a couple of things. This subject is heavy, hot subjects that have lots of regulation, logistics behind it. Unfortunately, I have nothing to disclose on this topic, and I have no conflict of interest regarding it. We will go through a couple of definitions and what is death and what's the history of determination of death by neurological criteria, what's the practice guidelines that is currently available, and how we assess these patients, and when and why should request ancillary testing in this. And in this very hot, as I mentioned, and a very legal topic, how we can document the documentation of this safely. And we will encounter special conditions regarding the pediatric age group, pregnancy, and patients post-cardiac arrest, how we declare them brain dead, and the semantic support during that time, and what is the controversies and the variations among the practice, and what is the local practice in Saudi Arabia. So we'll try to be very comprehensive in this topic. However, it will be concise. So what's definition of death, or what's death? All of us know that death is, by layman term, is the cessation of the respiratory and cardiac function. With the progression of medical practice and over the years since the late 1990s till now, the medical life and the medical practice has been changed, and we face lots of cases that is not typical for the usual death. So in the late 1960s, two neurologists, a French neurologist, faced this condition that the patient have no brainstem function and they are comatose. However, their cardiac and respiratory function is still there. And these patients didn't wake up, and after a while they sustained a cardiac arrest. So in that condition, the part of the definition of death has been shifted to a new term or a new definition, which is the brain death, or death by neurological criteria, which is the irreversible cessation of all function of the brain, including the brainstem. That's the unified definition of Death Act that was a part of the history of brain death declaration. So as I mentioned, in 1950s, two French neurologists, Mollard and Golan, tried to describe and understand what is brain death. And they put it in a simple term, it's called medibase. Harvard Medical School later on takes some contribution in determination of brain death, and they put a small definition, or the earliest definition of brain death, which is the cessation of the brain function. Then Uniform Death Determination of Death Act take a lead in that, and they define it as I mentioned earlier. Then the American Academy of Neurology take the lead and they put a guide for clinical practice. These guidelines helps to unify the practice all over the globe, so we can have like a foundation for what we practice all over the countries. So American Academy of Neurology put 5 solid guidelines that help any physician who is encountering these patients, especially intensivists, neurointensivists, neurologists, neurosurgeon, pediatric neurologist, to work through these patients that literally a very difficult, tough situation to declare them dead. When the family say their cardiac still working and their respiratory function is still working, their blood pressure is maintained, and they keep questioning why you determine them as dead patient when their heart is still beating. So American Academy of Neurology start to put the guidelines of these patients or these situations. So they start the first and the most important part is to establish the cause and establish the futility of the cause. Putting in mind, you have to exclude all modifiable and reversible factors. So that include lingering effect of sedation or medication, like any intoxication like alcohol. And the patient should have absent brainstem reflexes, and they should be apneic. And the apnea should be examined not only by seeing the ventilator, the patient has not putting an effort to start a breath. So you should have a well-established exam to determine that the patient is apneic. So these 5 guidelines or 4 solid pillars from the American Academy of Neurology, extensively putting a prerequisite for these, like when this patient is comatose, so why he is comatose, and I have to establish, is this reversible or irreversible? For example, in a neurology coma, we know it's an only presentation for underlying cause. So I have to establish what's the underlying cause of coma. Is this reversible or irreversible? For example, we have reversible cause of coma like hypothermia, hypoglycemia, and also one of the causes of coma is status epilepticus. So all of these are reversible causes that I can treat or I reverse, and the patient possibly will wake up. So I have to establish that the cause of coma is irreversible, and I have a brain imaging that describe or explain why this patient is comatose. So CT scan that is normal will not give me any hint that there is a structural lesion that lead to coma. So I should have abnormal CT scan that explain why the patient is comatose and the cause of coma is irreversible. The patient have absence of spontaneous respiration and ventilation. And as I mentioned earlier, there should be no lingering effect of sedation, no endocrine or metabolic abnormalities that can lead to coma. And one of the things that we have to put in mind, hypothermia can mimic brain death. So we should rewarm our patient before saying they are brain dead. Hemodynamic stability is very important before declaration of brain death. I cannot declare a patient his blood pressure is 80 systolic as a brain dead, because during hypotension, our sympathetic system is working. That will give me a fixed dilated pupil somehow that is non-reactive. So I should stabilize my patient from the hemodynamic point of view, trying to increase their blood pressure more than systolic blood pressure more than 100 and their core temperature more than 36. So to proceed in determination of brain death. So for example, if you have patients in your unit that have this CT scan is showing a huge brain or significant brain edema with effacement of the sulci and gyri and also compression in the ventricles. So this patient, by the CT scan, he has irreversible brain damage that cannot be reversed, and that is explained why he is comatose. As this patient has a GCS of 3, is this patient is having absent brainstem reflexes and there is no lingering effect of sedation. He is hemodynamically stable, or I stabilize him with inotropes and his core temperature is 36. This patient is possibly a candidate to determine his death by neurological criteria. Also, this patient is subarachnoid hemorrhage. So the CT scan is your gold standard to determine if this patient has a structural cause of coma that can be irreversible and lead to brain death. So, as I mentioned, the American Academy of Neurology put the guidelines, and one of the guidelines or the prerequisites is to examine your patient without effect of sedation or any medical or metabolic rearrangements. So how we assess these patients? The assessment of these patients in a clinical background, we have three components or three compartments. The first and the outmost of them is the GCS. And after determination of the GCS, that usually we know that the GCS has three components: the eye opening, verbal, and the motor. And if the patient gets only 3 out of 15, that means he is get 1 in each component of these. That is possibly the patient has significant or suffered a huge brain insult that lead to that GCS, and possibly the patient is a brain dead if he matched other criteria, which is absent brainstem reflexes and patient is amnesic. So the determination of brain death will go through step by step. First, determine your GCS of your patient. And as I mentioned, the GCS has 3 components: the eye opening, which will be 4 out of 4, verbal out of 5, and motor out of 6. If the patient gets 1, 1, and 1, he will get 3, and this is the initial part of the assessment. Then we will go to brainstem evaluation, starting with the pupillary reaction. As the pupils are fixed mid-position or fixed dilated and non-reactive, and then we will go to corneal reflex and facial grimace, and then we will go to oculocephalic reflex and caloric test. Oculocephalic reflex, we call it doll's eye. If you move the head of the patient right and left, and the eye is frozen, fixed in the socket, in their socket, and they are not moving, this is a frozen eye. And if you do the called caloric test and there is no movement of the eyes, also that will be a negative caloric test. And if there is no gag or no cough, and this is will conclude that all your brainstem of this patient exam is negative. And in that, you get 2 out of 3 parts of the exam is negative or favoring brain death. Then you will go toward couple of things that you have to put in mind or bear in mind and take attention on them during the examination, especially for the GCS. GCS, when we do it, we apply painful stimulus. For example, if you look back here, during eye opening, we first, if it is spontaneous, then we ask the patient to open with voice, and then we apply painful stimulus. Applying painful stimulus should be above the foramen magnum, so above the cervical areas. So you should apply painful stimulus on the orbital bridge or the temporomandibular joint when you assist your patient. If the patient has no motor response to that painful stimulus, which is central painful stimulus, that means he has no cortical function. But if you apply painful stimulus to the nail bed or to the shoulders or the sternal rub, and the patient has, for example, like a flexion-like movement, these movements are spinal cord reflexes. And you have to be very careful if you see these movements during a peripheral stimulation. And these are not cortical, and the presence of spinal cord reflexes will not exclude your patient from being a brain dead. So any plantar flexion or extensive plantar response is a spinal cord reflex. Triple flexion, especially if you examine or stimulate your patient in the nail bed or sternal rub. Abdominal reflex, remaster reflex, tonic neck flexion, isolated jerks of the upper extremities, unilateral extension or pronation movement, asymmetrical offset tonic posture of the trunk, undulating flexion microns, and respiratory-like movements, okay? And quadriceps contractions or something like periodic movements usually, and it is happen frequently, and the nurses will report to you when we change the blanket or change the position of the patient, there is abnormal movement happens to the lower extremities, and these are only spinal cord reflexes rather than cortical function. And you have to bear this in mind, especially these during the harvesting of the organ with the patient in the OR table with the first incision. Most of the patient will have these abnormal movements, so don't shock. These are spinal cord reflexes that rather than cortical function. Okay, so for example, you can see here in this video, when he is trying to move the head of the patient, he has flexion-like movement. He is applying supra-orbital painful stimuli, and there is no movement. Also with the temporomandibular joint stimulation. Sternal rub, he has also no movement, but now when he is flexing, this movement happens. And this is the problem of the family when they saw these abnormal movement, not spinal in origin. They will think that their beloved people are still with them. And usually the family, they say, we scratch his lower part of his foot and he has this movement. And this is movement you try to convince them this is a reflex rather than a significant or a purposeful movement, like Lazarus sign. So after doing the GCS and determining that GCS of your patient is only 3 and he has absent brain and reflexes, you will go to the apnea test. And here our RTs will have their happiest time. I think no RT will hate apnea testing. They love apnea testing and they love to be part of it. So, and as a neurointensivist or any intensivist, you have to have precautions or a prerequisite. So in brain death declaration, you will see in each step you should have a prerequisite. You fulfill your prerequisite first, then you go in the process. If you didn't fulfill your prerequisite, you cannot go to the process. So the precautions here, as I mentioned, we cannot do apnea testing as we cannot do the brain death declaration in patient who is hemodynamically unstable or who is hypothermic. The same happens, or the same goes with the apnea testing. The temperature, the core temperature is not the service temperature. The core temperature should be 36.5 and above. Systolic blood pressure 90 and above, and patient should be at the time of apnea testing should be either euvolemic or they have positive fluid balance at the last 6 hours before the exam. They shouldn't be volume depleted. Why? Because during apnea testing, lots of hemodynamic changes will happen and the patient should be hemodynamically stable during the test. If they become hemodynamically unstable and their heart and blood pressure drops down, the apnea test should be aborted. And you should substitute that apnea test with an ancillary test. So these are the prerequisites. The core temperature should be 36 and above, systolic blood pressure 90 and above, and the patient should be positive in positive bands. After reaching and achieving all of these prerequisites, you will pre-oxygenate in the ventilator. You will not disconnect. So you first part, the patient should be in the ventilator. You will put them in the FiO2 to 100%. You will decrease the respiratory 10 breaths per minute and the beat was 5. And then after 10 minutes, you will draw an ABG. And this is your baseline ABG in 100%. Couple of prerequisites in this ABG, it should be, the BH should be 7.35 and above. And the BO2 should be more than 100 and the CO2 should be less here by mistake by more than 40. It should be 40, okay, not exceeding 40. And then after that, you will disconnect your patient from the ventilator, okay, and putting a suction catheter and the carina. And the suction catheter, or called insufflation catheter, which will run 10 liters of oxygen per minute. And for 10 minutes. During this 10 minutes period, you should observe a couple of things. You will open the gown of the patient. You will observe any respiratory movement. If you have very thin patients, lots of times the cardiac pulsation will deceive a couple of people as respiratory movement. Look and correlate this cardiac pulsation with your arterial line, and this will be very helpful for you. And try to be away from the side rails or away from near the bed, because any movement possibly will account as respiration. You will observe for the blood pressure, saturation, and heart rate. During this 10 minutes, if there is any respiratory movement, you will abort your apnea testing. If there is any hemodynamic instability, means that the blood pressure drops below 90, or the patient has arrhythmias, or the patient became hypoxic less than the saturation less than 85 for 30 seconds, you will abort the apnea testing. If the apnea test for the 10 minutes was safe sail, you will extract another ABG by the end of the 10 minutes. And the ABG at your last ABG, the CO2, it should be more than 60, or in patients who are CO2 retainers, they should be a raise on the CO2 by 20 millimeter mercury from your baseline. And then you will reconnect your patient to the ventilator. And if you are in a state or in a country that they will not need, okay, it is not obligation to have an ancillary test, this time your second ABG or your ABG after 10 minutes is the time of the death or brain death. Okay, and you connect your patient to the ventilator. So this is how it goes. Okay, and the nurses and the RGs will be very helpful in that. When you come things that will help you in this, the presence of a line. Especially, for example, I usually do one midpoint ABG. It will be if there is an arterial line. So I will be efficient. I will not waste time in searching for arterial pulsation. So this is how it goes. Sometimes we can have, if the patient, for example, a couple of patients we cannot do them, or I'll try to avoid doing an apnea test for them, which is patients who have cervical injury, high cervical injury, and patients who are neuromuscular weakness or who has chronic neuromuscular respiratory failure. In these patients, apnea tests should be avoided, and it will depend on ancillary testing. So as I mentioned, when shall I abort my apnea test? When there be a spontaneous breathing was witnessed, or when we have hemodynamic instability, blood pressure, systolic blood pressure less than 100, or a mean less than 60, despite inotropes. You try to maximize your inotropes and the blood pressure still keep going down. This at the time you have to stop your apnea testing, because patient life and patient safety is more important than continuing a test that will lead to cardiac arrest. If there is any sustained of oxygen desaturation 85 and less for 30 seconds, or there is an unstable arrhythmia occurs, all these situations you have to abort your apnea testing. You optimize your patient, or your dependent ancillary testing. Okay, so for example, here we have an ABG for a patient. This is a first ABG on ventilation, and the FiO2 was 100. The pH is 7.36, and the CO2 you see is 40, and the PO2 is 490. And after 5 minutes, because I usually like to have mid-position or midpoint ABG to see if I'm going in the right direction or not. So within 5 minutes, the BCO2 raised up to 20 millimeter mercury, reaching 61. And by the 10 minutes, it reached 71. So this patient, by apnea test, he is apneic, and he concludes, or he was within the GCs of the 3 and absent brainstem reflexes. If you are, as I mentioned, if you are in the country that only depends on apnea tests and you need ancillary testing, you are willing to announce your patient as death or brain death. Okay, but if you are working in a country or a state that should have 2 exams, you should do another exam including GCS and GCS and brainstem assessment, but we don't have to repeat the ILAE test. So only ILAE test, only one ILAE test, and you have to go later on to the ancillary testing. When we speak about the ancillary test, to be honest, in most of the globe, okay, it is not must. It is must in most of the Islamic and Arabic countries and a couple of states in US. So ancillary testing, we use it to, if we have something that we cannot do in the clinical assessment. For example, I cannot do in the brainstem examination. For example, the patient has a ruptured wall, and I cannot assess his pupils, and I cannot assess, for example, the atlasophatic reflex. In these patients, I should have a formal ancillary test to compensate for things that I miss. Or, for example, patients who are having high cervical spine injury, or patients who has neuromuscular respiratory failure, chronic patients, I should have an ancillary test because I cannot do an ILAE test for them because they will be hemodynamically stable. They will. So in these cases, I should do ancillary testing. So what is the criteria for this test to be an ancillary test? Or what is the ideal test? We have lots of tests. So what are the ideal tests? The ideal test, it should have no false positive. It is sufficient by its own to say, is this patient brain dead or not? It is not susceptible to confounders. And that's where the EEG stands lower in the list because it's affected by the sedation. It's affected by the metabolic issues of the patient. So in these circumstances, EEG stands very low in the list, and I'm sorry for that, but it is per the guidelines. The EEG is not the best or the ideal ancillary test. Even it's in the list, but it is not the best. The test should be standardized in technology, techniques, and classification for the results. EEG has that. Unfortunately, it has not the confounder. The test should be available, safe, readily available in the medical centers. And that's where we divide our ancillary testing to two groups. Test that depends on the blood flow and test that depends on the neurophysiology. If we go to the that depends on the blood flow, the gold standard among all of these lists, which is contained, I think 6 or 7 tests, cerebral angiogram or digital subtracting angiogram for vessels is the gold standard because it has no false positive most of the time, specificity and sensitivity 100%. The problem with it is the using of contrast, and you have to ship your patient to the angio suite. And if your patient is unstable, that where the complication or the hazards will happen, and you have to depend on other tests. So the gold standard is cerebral angiogram. Unfortunately, not all hospitals have cerebral angiogram or angio suite, and not all your patients are suitable to it. After that, we have the radionuclide angiography and the radionuclide perfusion scintigraphy like SPECT. SPECT has its own limitation also because not all the centers have SPECT, and you have to ship your patient also to the machine. And the specificity and sensitivity from 98.5 to 56 as a specificity. When we go to the machine that I love, which is ultrasound, transcranial Doppler, I love it. Maybe I have a bias toward it, but it is easy. It is reproducible if it is done by expert, but unfortunately 10 to 15% of our patient has no window or they are difficult in windows, and most of them, they are females. So the criteria of it, they have absence of blood flow in the intracranial part. Okay, so we have, for example, the extracranial flow there is, but the intracranial, when the arteries go to the intracranial, we don't have flow. This is the same criteria for DSA, for the radionuclide, and for TCD. There is no intracranial flow, but there is extracranial flow. And for the TCD, you should do it in both sides, in the left and right, and you should do both anterior circulation and posterior circulation, and you should repeat the exam 30 minutes apart. As I mentioned, we have 10% of population have difficult window and you cannot access anything. In this patient, you have to depend on other modalities, either DSA or what is available in your center. Then we go to CTA and MRI. CTA and MRI, they are feasible. Most of the centers they have, but the problem, we don't have a standardization for them. And the contrast will depend on the cardiac cycle and the time that the contrast or the infusion is giving. So possibly you will have false positive or false negative result. That was not standardized. That's why the sensitivity and the specificity has been changing. For example, for CTA from 52 to 97 sensitivity and the specificity 100. And for MRI, time of flight could give you some abnormal results because, for example, if the patient has ICH, the blood flow will be compressed, so possibly it's a compression of the blood flow through the tumor rather than there is no flow. And that's why the sensitivity reaching up to from 93 to 100 and the specificity 100. So here is the arrangement is depending on what's the ideal or the most gold standard to the least gold standard or the least ideal test. Okay, now we will go to the other arm, which is the electrophysiological function or the electrophysiological test, like EEG, somatosensory evoked potential, auditory evoked potentials, and visual evoked potentials. All of these will have some affection due to presence of sedation or confounders. And if something, for example, the EEG, we have very established criteria for the EEG in the brain death, how we do it, how we interpret it. Unfortunately, it's have some limitation. That's why it goes down the list. So, for example, diagnostic criteria, not detectable electrical activity more than 2 microvolt over 30 minutes of periods. Advantage is not non-invasive. Disadvantage, it is only assessing the cortical function, not assessing the brain stem. It will have some contamination from the environment, especially in the ICUs, and the confounder of sedation, hypothermia, and metabolic states of the patient. The concern is the confounders in that in EEG. Somatosensory evoked potentials, bilateral absence, electrical transmission to the somatosensory cortex and the brain stem. If it's absent. However, as we mentioned, it's have some confounder effect, and it's if the patient has cervical spine injury, it will be also affected, and this is the disadvantage. It has less effect, it will be less affected by the sedation or neuromuscular agent of the patient, for example, post-cardiac arrest. Auditory potentials is the same, confounded by sedation, profound hypothermia and isolated brainstem injury, and limited to the auditory cortex. So it will not have the holistic approach than the perfusion study as well, and also visual potential. So in that regard, as the last publication, all like for JAMA, they were doing an international study about that, and they favor digital DSA than TCM. So if we go to the, as I mentioned, we have a clear criteria by American Clinical Physiology Society guidelines regarding the EEG. The EEG should be complete setup of scalp EEG. The inter-electrode impedance should be less than 10,000 ohm and more than 100 ohm. The integrity of the entire recording system should be tested before doing the test. Montage of the electrocerebral inactivity interpretation should be electrodes that press 10 centimeters apart. So we don't use 10-20 system, we use 10 system. Sensitivity must be increased to maximum 10 millivolt for at least 30 minutes, so for recording. And if there is an electrocerebral inactivity at that period, that's when possibly patient is a brain death with the other exam. Filter setups, because we have to filter any noise from the environment and we have to catch any minimal activity of the brain. The setup should be between 1 to 30 filters. There should be no EEG reactivity for external stimuli, visual, auditory, or somatosensory, and there will be recording. The recording technician should be well qualified in doing this. So not all technicians can do it. They should be well qualified, and the integrity of system should be tested. That's why in Saudi Arabia we have the Scott team. They bring their machine. Okay. So here are examples of what we mentioned. So this is an EEG, which is indicating electrocerebral inactivity. They call it electrocerebral silence or flatline whatsoever they can. There is no activity. This is the SPECT, and when we see it, we call it the empty light bulb sign. You will have the anterolateral here, and you have the lateral images, and you will see the skull with empty cortex. Here is the TCD. This is the normal flow. Okay, we have upward flow, systolic and diastolic. And when the ICP increases, we have a systolic spike and very low diastolic. And in the brain depth and TCD, you can watch your patient how they progress. And this is how it's nice. You can know which stages your patient is right now. So patient will be first, for example, normal population will go from this. For example, if the comatose came, then brain edema developed, they will go like this in that situation. After that, we will have what we call systolic spike or revibrating flow. And then by the end of the things, they will have a flat line or there is no flow. But you cannot say, I didn't detect a flow if you don't know if the patient has a good acoustic window or not, or a good window or not. So you have to know if there is acoustic window or not. This you see the anatomy of the brain through the TCD. Okay, and this is an actual real patient. This is the systolic flow, but there is no diastolic, and the flow goes down back. So there is no forward flow to the brain. And this is what we call it revibrating or oscillatory flow in these cases. Okay, this is conclude how we examine our patient. So we examine our patient in a set of prerequisites. Then we go to a pathway or a guidelines of the examination that contains the GCS, which is the consciousness level, absent brain stem reflexes, and then if it's you work in a place where the NSAA test is must, you have to do an NSAA test. If it's only clinical, you will depend on the clinical, and you will use your NSAA test as a compensation for things that is missing in the exam. And then you go to the documentation. Documentation should be formalized by your transplant organizations, or you should mention all these parts clearly in your notes. So what's the etiology of coma? Is this related to a huge brainstem stroke? Is this related to subarachnoid hemorrhage? Is this related to post-cardiac arrest? All of this has to be documented. And absence of confounders. Is there any confounding agent for example, is there alcohol intoxication? We cannot declare alcohol patient brain dead till we know what's the level and we have an NSAA test. Full details regarding the clinical testing performed and their results, including amine test and laboratory values, neuroimaging results in relation to clinical setting, reasons and time why I'm using the NSAA test if I'm not in centers or in place that the NSAA test is must, and what's the time of death, and the time of death is variable. It's only if I'm working in a place, it's only the clinical exam and apnea test is the time when I have the last or the second ABG will be my time of declaration. And if it is using to exam the documentation of brain death will be with the second exam and so forth. And we will discuss this in the coming slides. And identifying all the practitioners who perform the evaluation. For example, you don't think the dermatologist will declare patient brain death. They can't. So people who are able to assess patient from a neurological point of view, like a neurologist, neurosurgeon, intensivist, neurointensivist, pediatric neurologist. These are the people who will be able to do brain death or documentation of brain death. But people who are not able, or physicians who are not able to do a neurological assessment below, they are not in position to declare patient death by neurological criteria. Okay, so time of death, as I mentioned, if in cases where the brain death or death by neurological criteria has been determined, and neurological examination and MSA testing is not needed, the time of arterial BCO2, that is the target, is your death time or time of brain death. If MSA testing is performed and it was must, it's the time where the apnea test, the MSA test has been formally interpreted. So you did TCD is the time where TCD has been interpreted, or when you did a DSA, when the time that DSA has been reported. If you are in centers or in the country that you should have 2 examiners or 2 exams, the time of death will be the second exam, is the time of second exam, if it's you only depends on the neurological in the examination. So this is how we document brain death. The documentation of brain death, it is not as easy as the determination of brain death. It is a legal document, and you have to be very careful, very meticulous during filling the papers and during the documentation. So why the patient is dead? When the incident has been happened, till you assess your patient. For example, in adults, patient sustained, for example, subarachnoid hemorrhage, and he came with GCS3. I cannot do the full assessment of a brain death immediately in the spot. I have to wait 6 hours. In pediatric age group, neonate, and the categories of pediatrics, we have different time interval, depending on the theory that the pediatric age group brain has the capability to reverse what's there, but adult brain, we don't have. So only we are waiting 6 hours. And also, for example, in Saudi Arabia, we will wait 6 hours from the initial consult, and we will wait 6 hours between the 2 exams, because we should have 2 exams. Okay, so we will speak now about special conditions that we will face in declaration of brain death. Not all the patients will come as adults, and not all of them will have females who are not pregnant. Pregnant females, they can be brain dead. So dealing with a pregnant lady, you will deal with the lady itself, which is brain dead, and you will deal with the fetus that is there and he is alive. So this is a very complicated situation that you have to take a very huge concern about both parties. So, and part of it is patients who are in ECMO for ARDS or post-cardiac arrest. So these are special conditions that we will face. So brain death is like any medical condition. You will see a couple of cases that's easy. You can determine them brain dead, and you will see the other extremes that you will ask yourself many times. Am I in the position? Am I in right position to declare this patient to brain dead or not? So ECMO patient and post-cardiac arrest, they are the groups that you will deal with in completely different situations. So it is recommended, for example, the determination of brain death in ECMO patient, we will go through the prerequisites, and if I have any confounding that I have to remove from circulation, and then we'll go to the clinical assessment. The clinical assessment to your GCS, brainstem reflexes, and then the and the variation here in the apnea. You can, if patient is in ECMO and ventilated, or in ECMO not ventilated. In ECMO ventilated, you will give 100% oxygen in lung via CPAP. You will pre-oxygenate your patient first with the 100% oxygen, then you will give it through CPAP and mechanical ventilation, and then you will disconnect your patient from ventilation, like we did in the usual patient. In non-ventilated patient, you will change the sweep, right? And you will oxygenate patient first. So oxygenation will depend on providing 100% oxygen versus the sweep gas. If oxygenation cannot be maintained appropriately, tests will need to be aborted. and you will use an NSAID test. Blood gas should be measured simultaneously from the distal and arterial line from the patient and both oxygenator circuits, titrating the sweep gas flow between 0.5 to 1 liter per minute to maintain oxygenation. And the PA should be less than 7.3, and BCO2 should be more than 60 or more than 20 from the baseline of the patient. So this is ECMO patient. This is the oxygenator. So you will take a blood from here and blood from the arterial line of the patient. So, and you can compare between the two results. Okay. Determination of death in patients who are post-cardiac arrest on TTM or target temperature management. Neuroimaging here is a must, and you have to obtain it. And declaration of brain death here, it should be wait for 24-hour post-reworking. So, and the CT scan may show you high ICD or herniation. So this is what you will put in your mind. So the first CT scan that I show, it's the patient post-cardiac arrest. So here is the flow or the diagram of the post-cardiac arrest patient. Clinical examination of a person who is in hypothermia and identify possibly brain death. So I will rewarm my patient and I will go to a brain imaging. And if brain imaging showing irreversible brain edema or huge brain edema, so I will go to the second part, which is 24 hours after rewarming, 36 degrees. I will administer and to assess if there is any lingering effect of sedation. If there is no lingering effects of sedation, I will perform my clinical examination and apnea testing, trying to declare or determine is this patient brain dead or not. If there is no lingering effect of sedation, if there is a lingering effect of sedation or muscle relaxant, I have to wait half-life of that sedation and then perform my clinical examination, or I perform the clinical examination and I depends on the flow studies as ancillary testing. So this is how we declare patients brain dead post-cardiac arrest who are in hypothermia or TTM. So rewarm your patient, obtain and brain imaging them and see the brain imaging because there is a huge edema that is irreversible. I cannot do anything toward it. And then if there is lingering effect of sedation or if there is no, I'm willing to go to brain death declaration. If still there is lingering effect, I should wait for 5 half-lives or I depends on ancillary testing. That's as a flow-dependent ancillary testing rather than electrophysiology. As I mentioned, electrophysiology will be confounded by the sedation. So after determination of the brain death or neurological determination of brain death, you will have a couple of things that you will have to do for your patient, especially if they are organ donors, okay? If they are pregnant ladies, and if the family refused the determination of death by neurological criteria. In these 3 situations, you have to have a somatic support for your patient. When we say somatic support is the preservation of the organs, it equals the preservation of the organs. So in these 3 situations, you have to have preservation organ protocol. Because if the patient organ donor, you should preserve their organs for the donation, harvest and donation. If the patient is pregnant, you should keep her as perfect as possible for the fetus to grow in a healthy way, and then try to deliver her by after the lung maturation, so after the 32 weeks of a pregnancy. And if the family refuse the death declaration by neurological criteria for a region or religious or moral issues, you have to support your patient, okay? So these are the 3 situations that you should support your patient or preserve their organ. And pregnancy has lots of issues during if the lady is pregnant and she is brain dead. You have to preserve her nutritional status for the fetus. You have to know what's the tocolytic medication that you will use. And you have to give her steroids for maturation of the lungs of the fetus and deliver her by the 32 plus weeks. So, and you have to, for example, if she is pregnant in the beginning of her pregnancy, for example, 12 weeks, and then she should maintain to 32 weeks, they should be tracheostomized at that point. So all of these discussions should be held and should be aware, and it's like a communication that will never end between the family and the Scot, and between the family and the transplant organ, or the who is responsible in transplant. Okay, so management or the somatic support that you will give for your patient, you should, as I mentioned, the blood pressure should be more than 100, and you have to keep that all through. And using drops or crystalloid, colloid whatsoever. And the preferred agent is Levophed and vasopressin. Why we prefer vasopressin? Because in couple, and usually with the brain that they will develop the actus insipidus or the eye, and we have to reverse hyponatremia and maintain their intravascular volume. So vasopressin will be a good option. Minimal tidal volume strategy to prevent ARDS in these patients, because brain death is associated with inflammatory response, and to prevent anything in the lungs, you should maintain that. Cardiac arrhythmias should be treated with amiodarone or magnesium sulfate. Corticosteroid should be started. Hemoglobin should be maintained, and patient should be euthermic. Okay, and maintain euglycemia and avoid any acidosis by sodium chloride bicarbonate replacement, and replace any electrolyte, because any electrolyte disturbance, especially magnesium, phosphate, and calcium, potassium can lead to arrhythmias, and arrhythmias will lead to cardiac arrest in these patients. So you have to be very careful, especially if your patient is an organ donor. Okay. This is the same, and now we will go to the controversies of brain death. And fortunately, there is a huge debate about brain death. It is not a simple story or a simple thing that we discuss it now, and it's what's mentioned in the lectures. No, the discussions with the families is very huge. The pathway of declaration of brain death is very huge, and it is very hot topic from the beginning when the patient arrives into your intensive care unit till the time they, for example, shift for another center where the harvesting is done, or if they shifting from the patient brain death to organ donor. All of this pathway is very hectic for the physician, the transplant organ, and for the family. So it's not an easygoing process. So in recent years, we have multiple controversies, because lots of in literature, when you dig and write brain death, you will have patients who came out from dead. Okay, they are really dead when they declare them brain dead. And this is the question. That's why lots of families will ask if you declare them your beloved ones into brain dead in a clinical background, they will ask for a test, like ancillary test, to prove that. If they agreed to prove the brain death with the ancillary testing, they will be happy to accept the truth that their beloved one is a dead or a brain dead. So why that happens? Because in literature you will see, for example, a 10 years old girl who had been diagnosed as a brain dead due to motor vehicle collision, and the family refused to withdraw her life support, and they refused the idea of being a brain dead, so they somatically support her, and she reached her 14 years of age, and then she gets her menses. So how come and this is, she already, how come she has her menses when we tell that brain death is the whole brain death, including the brain stem? So possibly there is areas of our brain still functioning, which is thalamus hypothalamus axis. So the definition when we say that all brain stem function than all the brain function that make us a human. Okay, so multiple reports a case of prolonged biological survival after brain death. For example, a lady who is pregnant, she delivered her fetus and she was all this, for example, 200 days she was alive, or she was brain dead, but her cardiac and respiratory function was maintained. Why? Because she was an inotropic support or in a somatic support for the baby. So this, when the hustle came, and when there no public orientation about that or public awareness about brain death, these are the questions that were raised and the stories will take over. There is both national and international variable information. As I mentioned, and keep repeating the same. For example, ancillary test is a must here in Saudi Arabia. You cannot declare, and you will see in the forms, we have to mention what's the type of test that we use and what is the result. So it's a must in lots of Islamic countries. And a couple of the states in US, yes, it's a must. In Canada, where I'm practicing, it's not. It's only the neurological examination or the clinical examination. And if you have any problem with the neurological examination or something that you cannot do in a neurological examination, or apnea test has been non-conclusive, you will go to an ancillary test. So, and you need only one exam or 2 exams. And by the way, each exam has 2 examiners in it. So you will conclude that you have 4 exams. So if you have only 1 exam, your brain death will be at the time of your exam, first exam, and if you have 2 exams, your brain death declaration will be in the second exam. So all of intricacies. So because of the literature and the hustle around the brain death in UK, they say any irreversible apneic unconscious should be recognized as death, and they equalize the death with a brain death. So when they say patient to brain death by legal, that it will be a dead patient. And the code standard, death entails that irreversible loss of essential characteristic, which are necessary for existing living human person. So if you lost your brain function and brain system, you are not these are the essentials part of it, of us as a human. And if we don't have it, we are possibly dead. So in the controversies part, like this is casual, you will look multiple religions and their thoughts about brain death and organ donation. So if we go to the Buddhism, they are accepted it by some scholars, but its imposition is not universally held. So there is variation between the same groups of people. In Christianity, you will see lots of variations among the American Baptists, the Eastern Orthodox, and the Diamond and so forth. Hinduism, they accept death in some authorities, but not held as universally as the Buddhism. Okay. In Islam, we have different sectors or different groups. If we go to Shiism and Sunnism, the Shiism, most of they accept a brain death, and Sunnism, they have mixed opinion. But for example, Saudi Arabia, there is the higher standards. They agreed that brain death is a death. Judaism, we have also controversies. So brain death is a huge controversial topic. And there should be, let's say, a local, in each country, they have their regulation, because you cannot sustain it like this. Okay. So in a couple of variations that we have also the recommendation time of interval of examination between the first and second exam in different group of ages. And I'm very lucky to have Dr. Muhammad with us. He's a pediatrician, so that's units 7 days to 6 days. You have to wait 48 hours between the 2 exams, okay? And you have to wait that time because their brain has the capacity to fight till the end. In an infant above 60 days to 1 year, that is 24 hours. In children above 1 year, you will have to wait above 1 year to the age of, depending, for example, in Saudi Arabia, we have childhood up to 14 to 16 years of age. In other countries, up to 18 years. So you will, in this age group, you will wait 12 hours. In adults, anyone who is more than 14s or 18s, you will wait only 6 hours between the two sets of exams. For example, in the children, adults, the EEG is separated by the same interval. In the neonates, infants, you have to have 2 EEGs, for example. This is the Saudi recommendation. And in adults, you only need an EEG. So Saudi Arabia, still the EEG is part of the ancillary testing that should be done and used. Okay, so going to the law of regulation, who is regulating the process in Saudi Arabia is the SCOT team. And the SCOT stands for the Saudi Organ Transplant Center, okay, or team. So this is, and they have a huge manual that you can go and read, and they are easily accessed. They are so cooperative team, and you can catch them and ask them any question. So we have a set of practical one to maximize the cooperation between the intensive care unit in Saudi Arabia and the organ transplant. We call it MISC. So you have to identify the possible donor in the new intensive care unit and try to contact the SCOT team as soon as possible. Facilitate the brain death determination process and optimizing the donor status in the ICU and the breaking bad news with the family. The physician, the intensivist or the neurointensivist or people who declare patient to brain death, they only mention to the family that their beloved one is a brain dead. They will not speak anything about the organ donation process. The organ donation process will be established by SCOT. Okay, facilitate the recovery process coordination by SCOT and establish the link between SCOT and the ICU staff. In most of the Saudi units, intensive care, there is a coordination for SCOTs among the nurses and among the intensivists themselves. So collecting a hospital donor administrative coordinator, collecting all donors' personal information, approaching donor families regarding the organ donation in coordination with the SCOT, follow up the post donation care and providing the support for donors' families, coordination with the SCOT and the ROC. ROC stands for the Regional Coordinator Office. So this is how we do it in Saudi Arabia. If I have one patient in the unit that's possibly an organ donor or a brain dead, we contact the SCOT as soon as possible to put them in the spot on inboard so we can go step by step with each other in each step of declaration. So this is how we document our forms in Saudi Arabia. In the documentation, we have 2 forms. The first exam you will see here, and the second exam. The precondition, which is, it is absolutely certain there is irreversible brain damage. Okay, it has been more than 6 hours passed from the initial insult and coma with no spontaneous respiration. You have to mention, is this yes or no? And you have to exclude all the confounder agent or something that is reversible, and you go to clinical examination. And then you will have here the consultant A and B and documentation. For example, here the confirmatory test that you use, like you will see an EEG, flat EEG, or absence of blood flow by cerebral angiography, radionuclide angiography, or transcranial Doppler, and where is the test and what's the results. And here also the apnea test, you will the same form, but here mentions the apnea test and what is the prerequisite before the apnea test done is patient is apnea coordinate. And usually we attach the APG with the forms. Okay, and after that, after we declare patient brain death, And the SCOT team, we approach the family that the patient is a brain dead. The SCOT team will approach the family about the what's the guidelines in the situation where the brain death is declared, and they will have the huge talk with the family about the organ donation, if they are accepting or refusing. If they are accepting, they will have this form to be filled upon what we call consent for organ donation. The power of attorney people will fill that, and then this patient will be shifted to where the center of harvesting will take place. Like, for example, in Eastern Province, the harvesting organ, the harvesting center is the King Fahad Specialist Hospital in Dammam. So they will harvest the organ there. This is also how things in a scheme will happen. So if I have possible, when I encounter one patient and I believe or I think this is a possible brain death patient, the ICU notifies SCOT. I proceed to declaration of brain death. If patient fulfill the criteria of brain death, they will shift from possible to potential, documentation completed or not. If documentation wasn't completed, patient will be excluded. For example, patient is not ARIC patient, the answer test is positive. This is not completed documentation, so the patient will be excluded. I'm sorry. And if the documentation has been completed, and the patient is eligible, and the patient fulfilled the criteria of brain death, and we think he is eligible to be organ donor. So the family, we will break the news with the family as a physician only that the patient is a brain dead, and the SCOT team will take the lead right now in discussion of organ donation. If the family accepted that, and the patient will be transferred to the center with the harvesting will done. If they accept, if not, the family SCOT team will inform the ICU about the family concern, and then the ICU will take care upon the coded status of the patient. And if the family accepting the organ donation, the patient will be shifted to the harvesting center, and then the recovery of the organ will happen. And we call this an actual donor. So this is possible deceased donor, potential deceased donor, eligible donor, and actual donor. A couple of definitions, you don't need to know them. But if I have patient who is possible brain death, okay, apparently post any cardiac arrest or possible after a severe traumatic brain injury or severe brain insult, this is patient possibly a deceased donor. When they fulfill the criteria of a brain death, they are potential. When they have fulfilled the criteria of brain death and they are neurologically stable or medically stable, they are eligible. And when they have the first incident of harvesting their organ, they are actual donors. So in 2019, before COVID, there was one patient who were, I think the Minister of Health at that time was very amazed by what happened in King Fahad Hospital of University and King Faisal and King Fahad Specialist Hospital in because the neighbors in the Eastern Province. So a female who came with subarachnoid hemorrhage, high grade. We declare her brain. We initially, within 6 hours, we did the exam, the first exam. After the brain insult, after the station, we did our best to restate her, but she didn't help herself. After 6 hours from the exam, we did the second, the initial assessment, we did the second exam. So we actually declared her brain death within 14 hours from her arrival. And then 24 hours later, they harvested her organ in King Fahad Specialist Hospital down. And she helped 7 different people to have their life back. Her liver has been divided and been transplanted to 2 patients. Her pancreas has been transplanted to other patients. Her kidneys also, both lungs and her heart also has been transplant to other patients. So one patient helps 7 patients, and I think this is a huge contribution and something that I think we have to raise the awareness about it. Things that help us in that and help us, and Scott will help you in any single aspect of that, is to have you and include you in programs that help you to recognize having the most updated things in the organ donation and transplant societies. So you can enroll yourself, keep yourself updated and learn something that will help the society. And with all things that was done in this lecture, I cannot say anything that I'm proud to be part of that team that is doing their best to help patients dealing in tough situations like declaration of brain death. It is not easy. And I think without that team that includes all the intensivists, all the nurses, all the RTs, and with the lead of the ICU chairperson, and he turned to be the hospital director, Dr. Shahram, Prof. Shahram. Without that, we cannot do it in King Fahd Hospital. I think all other centers in the area should have well-organized intensive care unit to do that. And all countries in the Mediterranean and African areas, I think they should have a well-established guideline to manage their patient and to go in that path safely, smoothly. And if you have any questions, the floor is open.
Thank you very much, Dr. Kauthar, for your comprehensive presentation. I really enjoyed your talk. The floor is open for any questions, and I think we already have 2 questions here. So the first question, Dr. Kauthar, is should acute renal failure be corrected before brain death assessment?
Yes, I already mentioned that it should be, any confounder agent should be corrected. And if you can dialyze, your patient will be much better. Okay, so any thing that will, let's say, confound your exam, because acute failure, acute renal failure, acute hepatic failure, they will have their impact on the brain function. They cause encephalopathies. So you don't know really, is this GCS that comes from the brain insult itself or the renal failure? So you have to clear what is there.
And the second question, if I think you touch upon this as well, if 2 exams are required, should apnea test be done twice?
No, it's only once in the last exam. And like in our form, it's the last exam you will do, and then this will be the last exam or the second exam.
Thank you, Dr. Kauthar. The floor is still open for any further questions, inquiries, or comments. For all attendees, please feel free to use the Q&A feature to post your questions if you have any. So I think you have one more question, Dr. Kauthar. Is it okay to do apnea test before the clinical exam?
So if we started, you have to know your patients like GCS3 or absence of brainstem reflexes. This is first. So if you will proceed to apnea testing, are you sure that your patient has a GCS3? So but you can do it, to be honest, but you have to be very sure that your patient is brain dead, comatose with GCS of brain, and their brainstem reflexes. Like if we go to how brain death progress or brain insult will progress, initially when you have any brain lesion that will compress the brainstem, it will compress the midbrain, then it will compress the bones, then the effect will compress the medulla oblongata. So when you reach that, the patient is apneic, that means your medulla oblongata or the respiratory center is affected. So, for example, this will be the last or the terminal part of your brain insult. So, for example, I cannot do that except if I know that patient lost all of the above. So, for example, if you are not sure that GCS of patient is 3, you aren't sure their bipolar examination is present or absent. So if you did an testing, maybe you harm your patient, you're then benefiting them in the acute stage. And we don't know really if it is, if you don't know really if your patient is comatose or with GCS of 3 or not.
Thank you, Dr. Kauthar. So there's one more question. Has there been data collected on the preservation of the fetus where a mother is brain dead? Will the medical professionals preserve the life of the baby in all circumstances? And have there been transplantations of neonates?
Transplantation of neonates? Okay, let me understand the question first.
So actually, it is 3 questions in one. So has there been any collected or data collected on the preservation of the fetus where a mother is brain dead?
Yeah, there is lots of literature about that. And according to, you can, the last JAMA publication in September 2022, there is a huge literature review upon this, and you can check that. There is lots of literature review upon the pregnant ladies and with a brain death.
And the second part of the question, whether the medical professionals preserve the life of the baby or the fetus in all circumstances.
Okay, we have here the what we call it, the advanced directive. For example, this baby is a contribution of 2 partners, the mother, which is a brain dead already, and the father. So if the father wants to preserve that fetus life, they have to preserve it.
There is one question which is not clear for me. I wish if they can elaborate more. What is the brain death protocol? So I think you already presented the local protocols, so I'm not sure if.
Okay, the local. If they ask about the local protocol. The local protocol will start first as the international protocol. You have to rule out any, you have to have the prerequisite fulfilled first. That means your patient is comatose and you know that the cause of coma is irreversible and the CT scan showing a huge brain insult, that patient cannot go out of it. And then you go to, and there's no confounders, and you go step by step that your GCS assessment, your brainstem reflexes, and your apnea test, and you have to have ancillary tests in Saudi Arabia.
So I think we have one more question. A young patient with global brain edema, lost all brainstem reflexes with metabolic acidosis. Should we wait until metabolic acidosis is corrected, then re-examine him, or this will not be reversible either way?
Okay. When we speak about brain edema related to metabolic causes, as I mentioned, your metabolic causes should be reversed. You don't wait for them, you reverse them. Actively, you reverse them. For example, patients with acute kidney injury, you have to initiate renal replacement therapy as soon as possible and reverse what is reversible. If you reverse what is reversible and the patient has significant edema that will not be changed, for example, hepatic encephalopathy is patient with high ammonia, and you dialyze them, that will be, you know, that dialysis will not change the brain edema, but will change possibly the consciousness level of the patient. So you try your best to improve the clinical status of the patient, and then after your trial, you can examine your patient without any confounders, possibly, and declare your patient brain dead. So you have to actively manage your patient to declare them brain dead.
Thank you, Dr. Kauthar. I wonder if there's any more questions. So let me just, it looks like there's one more question. For countries with no access to an EEG, the more traditional exams are used often by paramedics in the field. Does the paramedic exam count as a first exam, or is it 2 exams by a doctor?
Okay, regarding the who are qualified to examine patient or declare patient to brain death, paramedics are not included in the qualification of declaration of brain death per guidelines all over the globe, or at least let us say in our local guidelines. So the guidelines mentioned it as intensivists, neurologist, neurosurgeon, pediatric neurologist, neurointensivist. So anyone who can examine the patient and repeat the examination, especially brainstem reflexes.
Thank you, Dr. Kauthar. So let me just read this to the attendees. So the Global Health and Epilepsy Project database provides a registry of existing epilepsy projects throughout Africa, the Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. The database will provide you an opportunity to strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academia, nonprofit, or philanthropy to learn about existing efforts while offering a means to engage. On the next slide, please scan the QR code to receive your certificate. Also, there is a link in the chat box now to the certificate. Thank you all for attending this webinar. Thank you, Dr. Kauthar, and have a nice day. Thank you.